Чи знайома вам ситуація, коли лектор під час презентації дуже активно розхвалює конкретний препарат, який нібито є незамінним для лікування конкретної патології? Який ваш рівень довіри до його слів? А якби ви дізналися, що цей лектор має фінансову зацікавленість в своєму матеріалі, щось би змінилось? Звісно, це питання риторичне. Подібна ситуація називається конфлікт інтересів. У світі існує етична практика розкриття конфлікту інтересів, щоб дати лікарям необхідний контекст для правильного споживання інформації. Більшість передових вчених, науковців мають конфлікти інтересів, але саме розкриття забезпечує прозорість відносин між лектором, між професором та професійною спільнотою. Суть не в тому, щоб не мати конфліктів інтересів, а в тому, щоб їх розкривати. Кожного разу, читаючи наукову публікацію, звертайте увагу, хто був спонсором цього дослідження. Слухаючи лекцію, зважайте, були названі непатентовані назви препаратів чи назви торгових марок. Та вимагайте від академічних працівників, від лекторів, від професорів розкриття конфлікту інтересів. Не давайте пошити себе в дурні. Ні прихованому конфлікту інтересів.
Нашої студії, і я з превеликим задоволенням...
And this is my pleasure to announce another debut today. We have Patrick O'Brien with us, the leading consultant for OB-GYN of the University of London NHC Trust Foundation, the honorable reader to the London University, head of International Department of the Institute of Women's Health. And a very important topic of today about the management of pregnancies at the primordial condition.
Do you hear me well?
I hear you, yes.
Perfect. Thank you so much for joining us. Are you okay with the sound or still not?
Sound is okay, thank you.
Yeah, I'm trying to express my gratitude that you are so flexible.
Thank you very much. I'm just trying to control my slides here, but don't seem to be able to.
Yeah, you will go further with your slides in a second. Okay, let's proceed. I have already announced your talk. Let's start.
Okay. Can I control my slides from here, do you think?
Everything is fine. So we have a slide about 23 weeks. Yeah. Mm-hmm.
Okay, I'm good now. Thank you very much. Okay, well, thank you very much for inviting me. It's great to be here. I'd hoped to be in Kiev for the first time. I have to wait for another year. So it's Independence Day in the United States today, but actually it's real Independence Day in the United Kingdom, because today, for the first time in 4 months, we will be opening up restaurants and bars and hairdressers, so everybody is celebrating here today. It's lovely to be with you. So I'm going to spend the next half an hour talking about managing births at the limits of viability. Now, what do I mean by that? Well, realistically, we're talking about, certainly here in the United Kingdom, between 23 and 25 weeks of gestation. Although I'll mention a recent document from the British Association of Perinatal Medicine, the BAPM, which actually suggests that we should be talking about 22 weeks rather than 23 weeks, and I'll come back to that in a minute. So why these thresholds, or why this definition? Well, on the one hand, we know that certainly here in the UK, that less than 22 weeks, there is no hope of survival, whereas over 25 weeks gestation, there's general agreement that active management should be offered on the basis that outcomes are so good these days. Now, is this common? Well, certainly over the last few years, we have seen a significant rise in the number of these babies that we're looking at. So, for example, between 1995 and 2006, so a decade roughly, the number of admissions between 23 weeks and 25 weeks in the UK increased by a third and then continue to increase. So these dilemmas that we have about managing babies at the limits of viability, it's not a new thing, but what's happening is that it's shifting downwards in gestation. So for example, in 1980, Very few babies survived at 25 to 26 weeks gestation, whereas now the limit of viability here is considered 23 weeks, and as I say, a suggestion that we should start pushing that even down to 22 weeks. Now, of course, most of these cases are spontaneous preterm labor. A few will be delivered at this early gestation for a major maternal indication, like a major antepartum hemorrhage or fulminating preeclampsia. Very rare, of course, to deliver a baby for a fetal indication at such an early gestation. And over the next 25 minutes, I just focus on a few of the principles for managing these mothers and babies, and I'll just touch on them here. So first is counseling about the outcomes for the child, for the baby, for the child, and that's difficult, and I'll explain why in a second. Predicting preterm birth is an important factor, mainly so that we can transfer to an appropriate perinatal unit, which we know improves outcomes. I'll talk about steroids, magnesium sulfate, optimizing the timing and mode of delivery, answering the question, when should we monitor the fetal heartbeat? And I've put last on the list here, should neonatal intensive care be offered? And in fact, maybe that should be top of the list, actually, because most of your other decisions about how to deliver the baby, whether to monitor the fetal heartbeat, actually most of those decisions are determined by the question, would I be prepared, would a neonatologist be prepared to offer care to this baby or not? Now, this is a really good document from the Nuffield Council on Bioethics. It's over a decade old, but I would argue that the principles it expresses are just as fresh and relevant today as they were on the day that this document was published. So I really would recommend it to all obstetricians and neonatologists. And they set out the principles for looking after mothers and babies at this threshold of viability. And the principles are these. Number one, continuity of care. There's nothing worse for these parents than having one doctor or midwife come into them and say, this is the plan, this is the prospect for your baby. And then 12 hours later, when somebody else comes on shift, they come in with a different plan, different outcomes discussed for the baby. Senior staff should be involved. It is not fair to have junior doctors and junior midwives having these discussions with difficult, stressed parents at a very difficult time for them. Joint multidisciplinary team working is really paramount. You can imagine how difficult it is for parents to have an obstetrician come in and say, the chances that your baby survives are X, and then a neonatologist come in half an hour later and say, the chances that your baby survives are Y. We need consistent messaging, and we need everybody speaking the same language and giving the same message. An obstetric dating scan is important in all settings in obstetrics, but particularly in this case around the limits of viability, and I'll explain why in a second. And of course, documentation is really important in all of obstetrics, but particularly in these high-risk situations where litigation and complaints are commonplace because of the high incidence of poor outcomes. Now, just recently, in October of last year, a new document that I just mentioned from the British Association of Perinatal Medicine, and I'll refer to this a few times during my talk, and this is the document that is arguing that the outcomes now for these very small early babies are so good that we should be considering pushing the threshold downwards by a week or maybe even further. Okay, so some data. And I'm going to spend a few minutes on this table because I think it highlights very well the difficulties of counseling parents, women in this situation. So these are the Epicure data from the United Kingdom in 2006. And I'll explain in a minute while I'm looking at why I'm looking at data from right back in 2006. But if you look along the top here, this is the gestation from 22 weeks to 26 weeks and the outcomes in the various columns. So if we start at the top and look, for example, at 22 weeks, and you can see that at 22 weeks, at the onset of labor, 272 babies were alive. But only 152 were born alive, and only 41 of those were actually resuscitated and made it through to the neonatal unit. In other words, the majority of these babies alive at the onset of labor will not make it to the neonatal unit. On the other hand, if you look at 26 weeks gestation, you can see that the vast majority of those babies that were alive at the start of labor will be born alive and will make it through to the neonatal unit. And when you talk about survival, that translates into these figures. So if the woman comes in labor at 22 weeks gestation and says to me, "Doctor, what are the chances of my baby surviving?" I have to say 1%. Whereas if the neonatologist comes in half an hour later and says, "Doctor, what are the chances of my baby surviving?" they will say 16%, because they're used to quoting figures for babies at 22 weeks that come through the doors of their neonatal unit alive. And that is one of the reasons why it is so important to have multidisciplinary team discussions. Get your obstetrician and your neonatologist and your midwife all in the room at the same time so that the messages are exactly the same. Otherwise, you can imagine how confusing these mixed messages are for these poor parents in labor, stressed about what the outcome for their baby is likely to be. On the other hand, if you look at 26 weeks gestation, the woman asked me the question, "Doc, what are my chances of my baby surviving?" I say 75%. The neonatologist says 78%, almost the same. And of course, that's a reflection of the fact that most of these babies alive at the start of labor will survive and make it to the neonatal unit. Now, of course, survival is not the only thing that matters to parents or babies or society. Survival without disability is probably equally or perhaps even more important to many parents. And you can see here at 22 weeks, if the woman asks me, "Doctor, what are the chances of my baby surviving without disability?" I have to say 0.5%. In other words, about half of those babies that survive from that point will suffer severe disability. On the other hand, if the mother asks the neonatologist the same question, they would say 5%. Again, reflecting the fact that of those babies that survive labor, survive the initial resuscitation, get into the neonatal unit, a significant number will do a lot better. Whereas again, if you go right up to 26 weeks, you will see the question 75% will survive, and 59% will survive without disability. Again, reflecting the fact that a much smaller proportion of these survivors will be affected by severe disability. So are we getting better at this? Well, if you look at the results or the outcomes comparing the Epicure 1 to the Epicure 2 study, and again, I'll explain in 1 second why I'm looking at these slightly older data, you can see that survival did increase significantly from 40% to 52%. So definitely we, well, perhaps more importantly, the neonatologists are getting better at looking after these babies. But sadly, no decrease in morbidity, whether you talk about brain hemorrhage or chronic lung disease or retinopathy of prematurity. And why is that? Well, it is because the morbidity is shifting downwards in terms of gestation. In other words, babies are surviving more, babies are surviving at earlier gestations, but the burden of morbidity is the same, but actually it's in those babies that are surviving at earlier gestations. Now, this highlights another key issue of counseling parents in this situation. Because if we look at data from Epicure 2, so this is babies born at these early gestations in the UK in 2006, and the woman says to me, "Doc, what are the chances not of just of my baby surviving, but of having normal survival? And what will it be like in 5 years and 10 years? I can answer those if we look at Epicure 2, because Epicure 2, all of those babies have been followed up long-term with physical and neurodevelopmental examinations every single year, and publishing Epicure 2 at 11, these children at 11 years of age, and the follow-up continues. So I can say with quite a degree of confidence to the woman, this is what's likely to happen to your baby at age of 5, at age of 10, at age of 11. And those data will continue to come on stream as the years pass. The problem with these data, of course, is that they reflect practice back in 2006. And of course, many things have changed since 2006. So, for example, in the United Kingdom, we use magnesium sulfate for neuroprotection a lot more. That was almost unheard of in 2006. There have been development of perinatal networks. So most babies nowadays born at these early gestations in the UK will be born in a hospital at the center of a network of hospitals that has a high-level neonatal unit and a high-level obstetric unit. And we know from good evidence that that improves the outcomes for these babies. So things have changed a lot since 2006. So if I quote these data to the woman, I'm giving her out-of-date, or I'm giving her data that refers to out-of-date practice. On the other hand, if I look at more recent data, for example, from France or Sweden, that is great. That's reflecting practice that's more current, more up-to-date. But we don't have any long-term outcome data. So I can say to the woman, your chances of your baby surviving for a year are X, but actually I don't know what your child will be like in 5 years or 10 years' time. And the other big issue with this counselling is that even if you put together all of these big studies that have looked at these births at early gestations, then actually still the numbers are very, very small indeed. So it's another weakness. These are the most recent data. Embrace from the United Kingdom, Express from Sweden, and so on there, and a systematic review. So if you look at the systematic review, the bars on the right, you can see the survival data. So the most up-to-date data in terms of survival. And you can see that when you get up to 25, 26 weeks, even 24 weeks, survival is well above 80%. So, this is what the British Association of Perinatal are arguing, is that these outcome data are looking better all the time, even down at 22 weeks, systematic review, survival 20%. And in the UK, 35%. So they are arguing that our limit of viability should be pushed down perhaps to 22 weeks. Now, this is an infographic from the BAPM that I've just been talking about, and I think it's lovely. Because if you look down the left-hand side, you can look at survival 22 up to 26 weeks. And lovely, simple data. Look at this, 22 weeks, 7 in 10 babies die, the red dots. Very easy for parents to grasp this. Right up to 26 weeks where 2 in 10 babies die. Sorry, I said 7 in 10 survive. I meant 7 in 10 die. Right up to 26 weeks where 2 in 10 die. And over here, this is severe disability in the survivors. And back at 22 weeks, you can see the red is a third that have severe disability, that's of survivors. Whereas if you come all the way up to 26 weeks, it's only 1 in 10 of survivors that have severe disability. I think this is a fantastic infographic for counseling parents in labor in these early stages. And, the data will be different in every country, perhaps in every center around the world. But I really think that it would be very, very useful, at least for every single country, to produce an infographic like this so that you can put it in front of your patients. And it means that whatever member of your staff, whether it's a senior doctor or a junior doctor or a midwife, they can look at this and everybody is giving the same information to this couple. I think it's really important. Now, another issue we have is whether to quote national data or data from your own hospital. So my hospital is University College Hospital in London, UCLH. And if you look at the survival there from 22 weeks to 25 weeks, in the different data, the national data from the UK, so Epicure and Epicure 2, and Express, the equivalent from Sweden, and our data back from the same period, our data in yellow there. And you can see that our data from my hospital at any given gestation are better, much better actually than the national data. Now, I'm not trying to say that my hospital is fantastic, but we're at the center of a perinatal network, and we look after a lot of these babies born in early gestations, just as St. George's. Baski is speaking after me, and Asthma later, St. George's Hospital, exactly the same, the center of perinatal network. And if you do a lot of something, you become good at it. So should we say to this woman, the chances for your baby are based on our hospital, or should we quote the national data? Well, the truth is, what we do is both. And this is going back to the table that I showed you a little bit earlier. So 22 weeks at the start of labour, the woman asked me, "Doctor, what are the chances my baby survives?" And I say just 1% at 22 weeks. That's the national data, but our data from our hospital, I say, but in our hospital it's 13%. Right up at 26 weeks, national data 75%, our data 83%. Now you might say this is a little bit even more confusing for the parents, but we think it's only fair to give the parents as much information as we possibly can. Now, of course, it goes without saying that the outcomes are proportional to gestational age, and I think this is a nice graph for showing this. So, for example, if you look at the 22-week bar here, blue are all of those that died on the labour ward, brown are all of those that died on the neonatal unit, and green are those that survived to leave the hospital. And obviously the proportion at 22 weeks is small, whereas when you get up to 26, 27, 28 weeks, the vast majority of these babies that are alive at the start of labour will survive to leave the hospital. Now, the reason I show this graph is to make this point, that an increase of 5 days in utero, assuming that the in utero environment is favourable, not infected, not bleeding and so on, 5 days can double survival for these babies and can double neurologically intact survival. So if 5 days makes such a critical difference in how you're going to manage these babies, these women, then it goes without saying that early dating scan, measuring the crown rump length, is critical. And we're lucky in the United Kingdom that just about every woman that I'm looking after at these gestations will have had an early dating scan, so we will be certain how far pregnant they are. And that makes a big difference when it comes to managing. As well as outcomes being related to gestation at birth, outcomes are related to birth weight, of course. The graph on the left is the one that I've just been showing you of outcomes, survival related to gestation. The one on the right is the equivalent for survival related to birth weight. And of course, the pattern is much the same. And that is fantastic if you have birth weight. If you're a neonatologist, you have that luxury. If you're an obstetrician like me, you don't have that luxury. All you have is the estimated fetal weight. And you and I know that the margin of error in estimated fetal weight is large. It's at least plus or minus 10%. And it's worse at these very early gestations. So the very babies that you would like to have an accurate estimated fetal weight, it's least accurate. And it's even worse if there's ruptured membranes or the head is low in the pelvis, which is often the case at these early gestations. So we obstetricians are making our management decisions based on an estimated fetal weight that is highly inaccurate at these gestations, whereas the neonatologists, as I say, they have the luxury of an actual birth weight. And the point of that is that in my hospital, even when these babies need major resuscitation, the neonatologist will be as keen as possible to weigh this baby as soon as possible after birth, because it really will help to guide their neonatal management. The other thing that makes a difference is female sex. Girls do better than boys, and that persists throughout life, as we all know. This is a lovely facility, really, in the United States, from the Eunice Kennedy Shriver, NIH. And what happens here is that when this woman comes in early labour and starts asking you questions, "Doctor, will my baby survive? Will my baby be normal?" You just plug in all of these data. What's the gestation? What's the estimated fetal weight or the birth weight, once you know it? The sex of the baby, singleton or multiple, antenatal steroids given, and you plug all of these in, and then this computer program, it just spits out these data. The outcomes and the outcomes for mechanically ventilated babies, really, really useful. And I think, again, every country should strive to develop a program just like this. It takes a bit of work, of course, and needs a reasonable amount of outcome data, but every country should develop a program like this so that when the woman walks into any labour ward in your country, the doctor there or the midwife there can plug in the data and can quote these figures to the woman. Really, really useful. Okay, so I just touched on management there. So how do we manage these women? Well, I have to start by saying, actually, the evidence is really limited. You know, look at babies between 23 and 25 weeks, or women, pregnant women between 23 and 25 weeks, very, very limited data on which to base our management decisions in the literature. The numbers are small, and many studies don't specifically report this subgroup. They just say, let's say, less than 28 weeks, for example. They're a really heterogeneous group. What do I mean by that? Well, I mean, some of these babies come out hypoxic because the woman has had an abruption. Some of these babies come out infected because the woman has ruptured membranes for a few days. And some come out in very good condition because, let's say, the woman had fulminating preeclampsia and had to be delivered by cesarean section because of that. So a very mixed bag of babies and all lumped together when we talk about outcomes, which is not fair, really. There's selection bias, meaning that reporting of outcomes is much more likely to be from centres that have good outcomes and who look after a lot of these babies. And I've just talked about the big studies that conduct long-term follow-up, but they're few and far between. Most of these babies do not have long-term follow-up. In my hospital, these babies will be followed up by a special neurodevelopmental team until they reach the age of 18. Now, what about predicting preterm birth? We're not great at it, but it's important because we know from good, solid data that if a baby is born in a hospital with what we call a level 3 neonatal unit, so that's the highest level of neonatal unit, used to looking after these babies, survival is much better than if the baby is born at a peripheral hospital. So in the UK, we do everything possible to ensure that these babies are born in the right hospital. In other words, an in utero transfer rather than an ex utero transfer. And you and I know that if you transfer into the centre, if you transfer every woman who comes in with threatened preterm labour, you will be transferring in a huge number of women. So you have to use something to screen these women coming to your unit with threatened preterm labour. Use one of these things here. In our hospital, use fetal fibronectin. The beauty of fetal fibronectin is that its false negative rate is very low. In other words, if you do a fibronectin test and it's negative, the chances of this woman going into labour in the next 2 weeks are very small indeed, and therefore you can save yourself and the woman from transferring this woman into the central hospital. So what about trying to delay preterm birth? Well, I've been saying that a few days in utero can make a massive difference to survival and to normal survival. That's, of course, in the absence of something in the uterus that may be harming the fetus, like infection or ongoing hemorrhage that causes hypoxia. But we're not good, as you and I know, we're not good at delaying preterm birth. Emergency cerclage may be of some benefit between 16 and 28 weeks. That's a nice guideline here in the United Kingdom. Tocolysis at these gestations, not proven to be of any benefit. And in fact, some randomized trials of atosaban or GTN show poorer outcomes in the babies where you use these drugs. Why? Well, maybe because they artificially kept the baby in an environment that was harmful or unfavorable. Okay, what about giving steroids at these early gestations? Well, yes, good evidence. At 23 to 25 weeks gestation, a good study published in JAMA in 2011 showing that steroids reduce the death rate and reduce neurodevelopmental impairment at close to 2 years of age. Now, the NICE guidelines in the United Kingdom are a bit woolly, if you understand that phrase. 23 to 24 weeks, it says discuss. 24 to 26 weeks, consider. 26 to 34 weeks, offer. What does all of this mean? Well, I translate that in our hospital. Once the woman reaches 23 weeks, we would recommend that she has steroids. What about giving a repeat course of steroids if the woman is still pregnant a week later? Well, to be honest, that's rare at these early gestations. If a woman looks or convinces you that she's likely to deliver early, such that you give steroids, it is really, really unlikely that she will still be pregnant a week later. But if she is, and you think she's still at high risk of preterm birth, probably right to give a repeat course of steroids. This does seem to reduce neurodevelopmental impairment. That's a Cochrane review from back in 2007. What about antibiotics to reduce early onset group B strep infection? So if there is preterm, pre-labor rupture of membranes, don't waste your time doing a swab for group B strep, or at least, let me be more accurate, don't waste your time waiting for the result of the swab for group B strep. Give intrapartum antibiotic prophylaxis against group B strep once labor is established. In other words, penicillin. But remember, if somebody has signs or symptoms of infection, don't give that narrow spectrum antibiotic. Give broad spectrum antibiotics that also cover group B strep, such as coamoxiclav or clindamycin, for example. Okay, what about magnesium sulfate? Well, this is a landmark paper. That's a term that's used very frequently, but usually inappropriately. But this truly is a landmark paper showing that magnesium sulfate reduces the chances of cerebral palsy in preterm babies. And if you look at the risk of cerebral palsy, moderate or severe, was halved in the group that had magnesium sulfate, and the relative risk 0.55, so halved the risk. The number needed to treat to prevent one case of cerebral palsy is 63. And just to put that in context, to prevent one case of preeclampsia, we have to to prevent one case of eclampsia, we have to treat 100 women with preeclampsia. And we do that all the time. So to prevent one case of cerebral palsy, you have to treat 63 women. And it depends a bit on the gestation. So if you're less than 28 weeks, the number needed to treat to prevent one case of cerebral palsy, just 29. Over 28 weeks, you have to treat 265 women. Now, have to point out again, even in this big trial, that data specific to these early gestations, 23 to 25 weeks, very limited, very small numbers. But still, the evidence is convincing, even with these small numbers. So the national guidance, the NICE guidance in the UK, is do offer magnesium between 24 and 30 weeks of gestation, and we would probably offer it earlier than that on the basis that it's unlikely that there's any harm and it's likely that there is benefit. But sadly, if you look at that figure right at the bottom of the screen there, this is just 3 years ago in the United Kingdom, an audit of our practice showed that half of these women are still not receiving magnesium sulfate before the baby is born. Now, some of that, of course, is explained by the fact that women come in and deliver very quickly before there's time, or deliver at home and come in. So some of them you will never be able to give magnesium to. But the main reason actually is that for some reason this practice has not got into our DNA. It has not got into our psyche. So we're all used to thinking immediately about steroids in babies, in women that are going to deliver preterm. But still we need to educate ourselves to remember to give magnesium as well. What about the mode of delivery? Well, occasionally, cesarean section is the only option because of maternal indications like massive abruption or fulminating preeclampsia, but that's rare. And in fact, for all others, there are very few data to guide us when it comes to mode of delivery. One retrospective study from the United States saying that there was cesarean section reduced mortality a bit, but only on the day of delivery, not long term. When it comes to breech, should you do a cesarean section for a breech baby at these early gestations? No evidence. So given the potential harm to the mother that comes from cesarean section, then cesarean section specifically because the baby is breech, less than 26 weeks, not advised. The same applies to multiple pregnancy. So the guiding principle is you base your decision whether or not to do a cesarean section on maternal and obstetric indications rather than because you think it might do something better for the baby. It doesn't, or at least there's no evidence that it does. Bear in mind also the situation in which you might be tempted to do a cesarean section at these early gestation. So let's say, for example, you're monitoring the fetal heart, CTG, and the CTG becomes bad, bradycardia, whatever, and you do a cesarean section in that situation. So now you're doing a cesarean section in a very preterm baby that is likely to be born compromised, hypoxic. And the outcomes for those babies are likely to be a lot worse than the outcomes that I've been showing you so far this morning. So don't convince yourself that cesarean section is likely to improve the outcome for these babies. It's unlikely that it will. Okay, so how does that all of that translate into practice? So the Nuffield document guidance that I spoke about earlier gave some guidance on this, which I think is really helpful. And I'm going to go through it step by step. And I would start by pointing out that the gestations in the left-hand column can change. And I'll come back to that at the end. So in my hospital, at the moment, less than 22 weeks gestation, we do not resuscitate. Why? Because these babies have just about zero chance of survival. 22 to 23 weeks, the rule is do not resuscitate, but we might have the pediatrician at birth to confirm the maturity just in case the baby is larger and in better condition than we expected, particularly if there's uncertainty about the gestation. In other words, the woman did not have an early dating scan, and particularly in the light of the new British Association for Perinatal Medicine, the BAPM, data that I've been talking about earlier that are showing, better outcomes at these gestations. So the rule again, do not resuscitate, but probably have pediatrician at birth. 23 to 24 weeks, most in the United Kingdom, resuscitation would be attempted, but that means attempted, just to kind of attempt to stabilize the baby, but the neonatologist having a very open mind, and if the baby is clearly in poor condition, is not responding to resuscitation, or indeed, if the parents, following previous counselling about the outcomes for this baby, have decided against resuscitation, that should be respected at this gestation. 24 to 25 weeks gestation, usually resuscitation, do the best to resuscitate fully, then stop and reassess and make a judgment about this baby's prognosis and discuss it with the parents. And then finally, over 25 weeks gestation, the rule is to resuscitate and offer neonatal intensive care in the same way that you would for a baby born at 30 weeks gestation, because the outcomes over 25 weeks now are so good. Now that's very helpful. This is what Nuffield said, that document. It's very helpful if you're a neonatologist. It's not so helpful if you're an obstetrician. There's nothing there really to guide an obstetrician like me or you. So what do you do? Well, I have extrapolated from the Nuffield data based on this. So the first rule is if you're not prepared to resuscitate this baby, of course you should not be prepared to do a cesarean section. It would be stupid. The same, 22 to 23 weeks, do not do a cesarean section because the rule in general is not to resuscitate this baby. The same at 23 to 24 weeks, because even though resuscitation would be attempted, there are no data that cesarean section will improve the outcome for this baby. The same at 24 to 25 weeks. The rule would be generally not to do a cesarean section, again, based on the rationale that there's no evidence that cesarean section will improve the outcome for these babies. But there are some situations where we might be prepared to do a cesarean section. For example, last week, I was looking after this woman. She's 46 years old. She's had 10 attempts at IVF. This is the furthest she got in any pregnancy. This may be her last chance to have a child. She wants to do everything possible for this child. And we said, look, I cannot honestly say to you that cesarean section will improve the outcome for this child. But on balance, she said, I want to do everything possible. Let's try that. And so there are some situations where it might be reasonable, but still the rule would probably be not to do a cesarean section. Now, the recent BAPM document might argue with that, and that's certainly a discussion that's been opened up in our hospital between obstetricians and neonatologists. I think it's fair to say it's a difficult discussion at the moment because the neonatologists are looking only at neonatal outcome and completely ignore the implications of a cesarean section for the woman, and particularly the implications of a cesarean section at these early gestations, which may well be a classical cesarean section with the additional risks that are associated with that. And then over 25 weeks, because we're prepared to resuscitate these babies, then we should be prepared to do a cesarean section just as we will do at 30 weeks gestation. Okay, now what are the implications of that for fetal monitoring, for CTG? Well, of course, if you're not prepared to do a cesarean section, you should not be doing continuous fetal monitoring. Now that might seem very obvious, but I still walk onto my labour ward some days to a woman who's 23 and a half weeks and find that she's on the CTG. And I ask the doctors, why is she on the CTG? Well, we want to see if the baby's well or not. Why do you want to see the baby's well? And they stop and they think, well, I'm not sure, because they recognize that we would not be prepared to do a cesarean section. Do listen in to the baby's heartbeat every hour, perhaps, because you need to know, and the neonatologists need to know, and it's good for the parents to be prepared whether the baby's going to be born alive or not. But don't do continuous monitoring. Here, 24 to 25 weeks, if you've decided you're prepared to do a cesarean section, do CTG. If you've decided you're not prepared to do a cesarean section, do not do a CTG. And if you're prepared to do a cesarean section and offer resuscitation, etc., over 25 weeks, then you should do continuous CTG. Now, these are the gestational age thresholds that apply to this sort of plan of care, this plan of action for neonatologists and obstetricians in my unit. But I gave this lecture in Lucknow in India, and they said, well, actually, we're going to shift all those gestations up 2 to 3 weeks. I gave this lecture in Dubai, and they said, okay, those thresholds look okay to us. My point is that even though you might change the gestation thresholds in the column on the left there, the principles of management, both neonatal and obstetric, should be exactly the same in your unit. And I think every unit and perhaps every room with a baby, with a woman in preterm labor at these gestations, should have this sheet printed out and in the room so that everybody is clear about the management. Now, so my take-home message are these. Number one, discussing the outcome data is difficult because of all the limitations that I spoke about. The numbers are small. Trying to discuss whether we're discussing long-term, we got some long-term outcome data, but based on old practice, or we got some more recent outcome data, but not long-term. Discussing local figures, my hospital versus national figures. Tell the parents about the limitations of the figures that you're giving them. Be honest with them. Individualized care. So don't just say you're 25 weeks, this is the outcome for your baby. No, you have to say you're 25 weeks, your membranes have been ruptured a few days, we're a bit suspicious that there might be some infection, etc. So that the outcome for your baby may not be as good as the data I've just given you. Give steroids, it improves outcome. Give magnesium sulfate, don't forget. Give antibiotics if indicated. And importantly, at these early gestation, you absolutely must explain that the baby may die in labor. This is a very difficult discussion to have. I said right at the start, do not have junior doctors leading the counseling of these women, these couples. It's a difficult discussion to have, but you must have it. You cannot have a situation where you know that there's a high chance at 23 weeks this baby might die during labor, and you have not prepared the parents for it. Number one, it's unfair for the parents. Number two, it is extremely likely in that situation that they will blame you, and they will sue you, and they will complain about you because you haven't given them that warning. And they will imply from that you didn't realize that the baby might die in labor, and you should have managed things differently. And what follows on from that discussion, the decision not to be prepared to do a cesarean section. And again, you must have that discussion up front, because otherwise, if somebody happens to listen to the fetal heart and here's a fetal bradycardia, and you're in that situation, you're trying to have a discussion with the parents to say, your baby is dying and we're not going to do anything about it, it is impossible. You must have these discussions up front. And my experience over the years is that while I started by thinking that these discussions would be very, very difficult, actually, when you have the discussion and start by telling the parents the outcomes, and then say, and therefore we would not do a cesarean section because of A, B, and C, and therefore we will not do continuous CTG, actually, by and large, they understand and they accept it. Discuss with neonatologists, get the neonatologist to come and discuss what's likely to happen with the parents and visit the neonatal unit if that's possible. But ideally have the conversation with the obstetricians and the neonatologists and the parents all at the same time to make sure that you're not giving them different outcome data for the reasons that I said. And have these discussions early and keep repeating them, because the situation changes day by day and hour by hour, as you know, such that outcomes for the baby might change as we go along. Thank you very much.
Dear Professor Brian, thank you
Пане
for this
професоре Брайан,
brilliant and comprehensive talk.
дякую вам за
We
цю чудову
received
і дуже таку
real
комплексну.
pleasure. Thank you so much again. We have 4 minutes and we have a lot of questions. Are you okay?
I'm sorry I ran over.
Okay. So thank you so much again. The first question is regarding what dosage of magnesium sulfate do you use in your hospital for neuroprotection, and how long do you proceed with it?
So exactly the same dose as you would use for managing preeclampsia or eclampsia, usually 5 grams. There is not much evidence around this, but the aim is to have the drug in the woman by the time that she has the baby. That seems to make the difference.
Okay, thank you so much. The repeated dosage of steroids. There is data that maybe it's more safe to prescribe.
I've had situations where we've given the drug for neuroprotection, and then the woman has stopped contracting at 7 centimeters dilated and stayed like that for 12 hours.
Okay, thank you. Do you hear me well? Of course, there was a short interruption into the connection. Do you hear me right now?
You broke up there. Please ask again.
There was a little break in the connection, but we understood the answer for the previous question. So the second question is that what do you think about the option of half dosage of betamethasone for the repeated introduction?
I think at these early gestations, as I said, it is really unlikely that you would give steroids to a woman because you're convinced that she's going to deliver, and then find that she's not delivered 7 days later. So I think it's very unlikely that you will be in that situation. But if you are, there's some evidence that giving a repeat dose of steroids is fine, produces some benefit. Now, you know that we're always concerned about the risk of repeated doses of steroids and damage to the neonatal or the fetal white matter in the brain. But in this situation, as I say, it's rare, but there's some evidence that on balance, it's a good thing to do. In terms of half doses, no, I don't think there's any evidence around that. I think if you're deciding to give steroids, then you give the normal doses.
Okay, thanks a lot. Do you administer surfactant for these children directly in the delivery room or in the operative room?
Again, this is a neonatal question, but the answer is yes. The neonatologist will give surfactant as early as possible at these early gestations so that it can facilitate even the early resuscitation.
Do you have any data or observations that children that were born from mothers with preeclampsia usually are doing better, so they have better survival results?
I think that's a very good question. And it depends on there's associated placenta deficiency, which, as you know, is commonly associated with preeclampsia. But if you compare a baby that is delivered because we're worried about the mother's severe preeclampsia and the baby is born in good condition, compare that baby with one who's born early because the woman had ruptured membranes 5 days ago, gradually developed some intrauterine infection, went into labor and delivered the baby. So the baby is born with a degree of infection. Those two babies are likely to have very different outcomes. We know that outcome or cerebral palsy is often much worse, or there's a higher risk of it when you get the combination of prematurity and infection. Those two things combined really multiply the risk of cerebral palsy. So the answer to your question is yes, often, for the reason that these babies with preeclampsia are often born in better condition because the indication may be primarily maternal.
Okay, and the last question, maybe because we are short of time, the question was regarding the cesarean section and the statement that maybe it does not improve the result for the baby. But if there are some special circumstances, some special conditions, like, for example, breech in twins, and 27 weeks. Will you go further with cesarean in this case?
Yes, so I think over 25 weeks, that applies. But when you get to gestations less than 25 weeks, there is no evidence that cesarean section in this situation will improve the outcome, particularly, as I said, because you're only likely to do a cesarean section if there's an abnormal CTG. If you want to make that choice purely on the basis that there's a breech presentation of the leading twin and its twins, there are no data out there. Now, you might argue, well, lack of data does not mean that there's no benefit. That may be the case, but there's no evidence of benefit, and we know that there's a high chance this will be a classical cesarean section with the implications in terms of hemorrhage, future pregnancy, etc.
I'm just, so even if, for example, we have 25 weeks, first is breech, the second is vertex, let's say, so we are, for example, afraid of collision, whatever, or in this week it doesn't matter. I mean, or in this term it doesn't matter.
So in our hospital, which as I say, it's kind of a high-level hospital, looking after a lot of these babies, the cutoff delivering the baby purely because of breech presentation is 25 weeks. So over 25 weeks, yes, we'd be prepared to. Less than 25 weeks, no, we'd not prepared to. Now, you might argue that's a very arbitrary cutoff because, you know, does one day make all of that difference? But you have to set these cutoffs somewhere.
Yeah, and the same doctor, the second part of the question is regarding what will be the tactics, the way of delivery for this situation, I mean twins and first breech, after 28. For example, 28 till 34.
After 28 weeks in our hospital, we would do a cesarean section here. Now, you know, of course, sometimes in this situation, if somebody comes in advanced preterm labor, there isn't time to do that, or it would not be as safe to do that. But as a rule, we would be prepared to do cesarean section if the leading twin is breech at that sort of gestation.
Thank you so much, Pat. I always say who thinks well formulates well. It's always a pleasure to listen to a real professional, to a practical doctor. Thank you so much. I hope the next year we'll have a chance to communicate here in Ukraine and to spend great time. Okay.
Thank you very much.
Say Asma that she has a very nice dress, and we are waiting for her in actually almost 2 hours. Have a nice day.
I'll tell her.
Thanks a lot.